Good morning and welcome to this online CME. I wish to thank Professor Edward Johnson and my teacher, Professor Kundra, on this occasion of this CME. Good morning, everyone. Today's talk is about perioperative anemia, management strategies. This is the topic given to me. Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar. So this is our college institute and our theater and our machine. So when I go and to see the internet and the books for this management strategies of perioperative anemia, I can see innumerable guidelines. This is 2016 guidelines. This is Turkish guidelines. This is European guidelines. This is so many guidelines are there so that we can do only this. After reading this, we have to go into this stage. So why was the topic given by doctors? Why should we know about this topic, perioperative anemia management strategies? Now, here you see, if the patient is 18 years old and is having moderate anemia, there is an increased chance of postoperative blood transfusion and there is some risk of death. So, if there is a preoperative anemia, there is an increased chance of transfusion, increased risk of death. This is one of the reasons that we need to understand what is perioperative anemia. Now you see here, in cardiac surgeries, in gastric cancer surgeries, everything outcome depends upon your hemoglobin levels. Also, this parts a major role here. Hence, we need to know about this anemia and today's importance of this topic. See, many husbands are like this. So our anemia is not like this. It's not an innocent bystander. It worsens cardiac illness. It worsens renal failure. It increases hospital stay, thereby the cost. Now, what they call is patient blood management, PBM. What is this? It's a multidisciplinary. No, it is not only anesthesia, surgery, anesthesia, medicine, transfusion medicine, hematology. It's multimodal. So you cannot give only iron oral. It may be iron supplemental, intravenous also, blood also, homogeneous blood, allogenous blood, so many things. Patient-centered strategy. What is the patient like? How is the patient? Aimed at minimizing the use of blood products. Lot of blood products should not be there, but patient's outcome should be good. This is what is called patient blood management. So I'm not going to go so much into theory now. Whatever I want to tell today is about some experience, some book and some journal like that. So we will go to preoperative anemia, intraoperative anemia and postoperative anemia. So these three things are actually combined as perioperative. Now preoperative anemia, if you go into the guidelines, they say 12 for females and 13 for males. There is also a strong objection to this. Why should females be less than 12 and why should males be less than 13? Both are equal. Something like that is happening in UK also. So 12, but Indian is 10. Mild here is 8 to 10. So what we have is around 7 to 8 is moderate, around 7 is severe, and 8 to 10 is mild, or 10 is normal. Many of these things talk about non-pregnant patients only. So pregnant patients scenario is different. What is the incidence of preoperative anemia? If you take it as 13, no, almost all 75% of our patients will be anemic. And if we take it even as 10, 1/3 of our patients, preoperative patients, are anemic. That is what the evidence tells. If we take it even as 10, 1/3 of the patients are anemic. Now I have already told cardiac mortality increases, transmission of blood and transmission of blood increases, thereby the transmission of illness, cardiac illness worsens because the cardiac output increases, SVR decreases, the oxygen delivery decreases. So increased oxygen extraction by the skeletal muscles. But in brain and heart, already it is fully extracted. Because there is some anemia, it cannot extract more. This problem is there. In the setting of hypoxia, in the setting of shivering, and in the setting of pain. 1, 2, 3. These are very common in the perioperative period. In the setting of hypoxia, in the setting of shivering, in the setting of pain, we have some problem with oxygen delivery. This is what we don't want. Why should anemia occur? Anemia can occur because of bleeding, inflammation, nutritious, chemotherapy, and drugs. This is not a classical hematology decroci definition. This definition is more towards the causative etiological focus on the perioperative period. Now you see acute bleeding, rupture ectopic, placenta previa, trauma. All these things we cannot say the hemoglobin is 6. Boss, I'm not taking up the case. We have to take up all these things. Chronic is a GI bleeding if they are going for endoscopy or if they are going for some other procedure. A DUB, a colonic polyp. See, for example, in DUB, they may go for fractional curettage. The hemoglobin will be around 8 or 9. Okay. Now you give blood. What happens at the time the next period comes, the cycle comes, she will bleed whatever you have given already. So it is some sort of semi-emergencies. So we cannot go and make unfit every patient. Or this may be a possible malignancy. If they do a fractional curettage, they may detect a malignancy in 2 days. But if you give iron for 8 weeks and then take up the case of hemoglobin picking up from 8 to 9, then 45 days to 50 days of malignancy is lost. That we have to think and then give fitness in time. Now, we have one more thing. This is the normal uterus. We have a myoma bigger than the uterus. This myoma bigger than the uterus needs to be taken out. Because if the next bleed, it will bleed another 5 ml. So this has to be taken out. So whenever you see PAC, hysterectomy, myomectomy, see the size of the myoma. See size of the myoma and then see hemoglobin, then correlate well, talk to the surgeons and then make the case fit. Now we have chronic inflammation, rheumatoid arthritis, CRF and all. Rheumatoid arthritis unlikely to become more than 10. CRF unlikely to become more than 9. There are two more interesting cases in the preoperative period which we commonly come across is pyocele and Fournier's gangrene. These two patients will not have high hemoglobin levels. Hemoglobin will be moderately or mildly anemic only these cases. Because of this, we cannot make the patient unfit. So this has to be kept in mind. Anemia may be an associated thing in this. It will take long time to pick up this hemoglobin because the sepsis will cause this problem. So we may need to do the surgery and then treat the anemia. Chemotherapy, myelosuppressive drugs, radiotherapy and erythropoiesis. All these things are problematic. You cannot have hemoglobin of, for example, heparin, gatrons, clopidogrel. So many drugs can cause problems with hemoglobins. Now we have iron. There may be problem in absorption or there may be bad diet. So the ideal drug which we use is ferric carboxymaltose. We give usually 500 milligram, one dose, followed by next week one dose, or sometimes followed by oral iron, vitamin B12 and folate tablets. So the pickup we can wait for 8 to 12 weeks or 4 weeks after parental iron. So 4 weeks, if you give 2 doses followed by oral folate and B12, yes, parental iron pickup. Elective case, is it okay? Most of these patients, we need to investigate anemia. That is very important. Take a peripheral smear. See also the platelets. See also the total count. See an expert opinion. So we may need to basically test all these things. Yes, we can also go ahead with testing in patients with microcytic hypochromic anemia, possibly transferrin levels and all these things. But be specific in taking an ultrasound abdomen because there may be splenomegaly. If you have splenomegaly, your hemoglobin is unlikely to go up 10. So it is a destructor of RBCs. you get some sort of pancytopenia. So take up these patients. You cannot increase the hemoglobin by giving iron alone. Pick up the case, get the splenectomy done, and then whatever is the ideal thing, compromise there. You have to go for prothrombin type. It is very important. So these are all the basic investigations for identification of cause of the anemia. Yes, preoperatively, we need to work up on the cause of the anemia. It is a chronic inflammation. I already told CRF, rheumatoid arthritis, usually parenteral anesthesia. Myelosuppressive drugs, we cannot go. As for example, the patient is a myelosuppressive drugs or some CML, chronic myeloid leukemia, and the patient develops humerus fracture. It's not a pathological fracture, it develops a humerus fracture. So how long will we wait now? We can give iron, blood, and all these things all, and wait for 6 weeks or 8 weeks, something like that. There we have to decide on other transfusion if the patient is anemic. Yes, if it is going to be more than 10% of blood volume loss, if you expect in a surgery, think of blood transfusion. Think of. If you expect 10% of blood volume loss, beware. Take it out. Be ready with some other things. So 10 and 20%. This is not applicable to pediatrics. This is about adults. Now we have decided to give blood. Yes, this is the patient which needs blood. Autologous blood can be collected from 5 weeks to 3 days before elective surgery. Take the blood from the patient itself some 3 to 4 weeks prior and start giving intravenous iron, folic acid, B12, everything. So this will pick up by 1 gram in 3 weeks. So this will be okay. And then give the blood during the surgery. What is acute normovolumic hemodilution? I'm not going to the details of these things because it's a different topic, blood conservation strategies. You get the patient on the day of surgery, remove blood and give crystalloids 3 times and then use it after the surgery. What is the basic purpose is, now you have taken out 350 ml and you have given 1 liter. Now the 1 liter has diluted your whole blood. Now if the patient bleeds 350 ml, now you see there is some RL also is bleeding. Your finger lactate also is coming out. So we have got a better RBC level after the bleeding. Anemia less than 8 grams. Yes, consider preoperative transfusion. Preferable to increase up to 10 in elective cases. By which way? Preoperative workup for the cause 4 to 6 weeks prior, ideally. Now, we have a lot of, yes, we give blood. Okay. Now, what are the problems? There is an infection transmission, transfusion related acute lung injuries. But now, recent techniques and different evolution of this blood has come possibly towards safer blood. But if you have a low hemoglobin and if you want urgent surgery and if the patient is hemodynamically unstable, think of others' blood. Now, I already told in certain patients of CRF, what I do is I give 40 mg of darbepoetin alpha. This is an erythropoietin stimulating factor. So I give 40 milligrams and iron folic acid. I usually give naso B12 because if you pump this B12 is not very good in absorption. If you give prick every day, the patient may not be very happy. So I use naso B12, 2 drops, 1 drop each in this nostril every day. It is fine. Iron folic acid supplement along with this, we can expect a pickup of 2 grams in 3 weeks. So this is best even for chronic inflammation. Even for malignancies, give an erythropoietin stimulation, give iron folic acid, nasobetal, pick up the hemoglobin by 1 gram or 2 grams, then ready. 3 weeks only, it's not a big time. Now, what I want to tell is ectopic, yes, go ahead with surgeries. Bleeding hemorrhoids, very clinical condition. Common clinical condition, you will get hemorrhoids. If your hemoglobin is 8.5, what are you going to do? If your hemoglobin is 8.5, you are going to give iron, folic acid, B12, nasal, all these things and pick up to 9.5. The next time it bleeds, again it will come back to 8. That is where, if there is a hemodynamic instability, if there is an urgent surgery, if the hemoglobin is less than 7, then you go for blood and do. If it is more than 8, then do the surgery, do a post-op hemoglobin, see for all these things, and then give blood if it is necessary. Sepsis autoimmune serum. Yes, I always prefer to keep a hand on pulse. We are all old timers. You new timers are started seeing all these lab investigations and all. We used to put a hand on pulse. If a hand on pulse is not showing tachycardia, if it is not showing a bounding pulse, and if the BP is not showing 150 by 60, these are all things which patients tells that the patient is significantly anemic. And if there is no tachycardia, so all these things make tachycardia means there is some volume loss. High systolic, low diastolic means anemia is compensated by SVR reduction. So all these things make you think that this patient is anemic. Now we have got all psychiatric patients coming for hemoglobin with 9. Now can we give a patient of schizophrenia iron tablet and folic acid tablet and give after 8 weeks, come after 8 weeks? This is not possible. So we have to decide on case to case basis there. Can he take the drugs? He will not take even anti-epileptics. He will not take even antipsychotics. He will give the drug to his relative, his uncle, or something else. You are only having psychiatric illness. Something you will tell. Now, if the psychiatrist thinks that ECT is going to correct his food habits, give an ECT with 8.5 grams if the patient is otherwise okay, and then starts, if he gets okay, then starts giving iron, pick up the things. There are few more instances. You have long bones fracture. You have a fracture of femur. You have seen the pack. You have seen the day before. Okay. Now, what they will do is on the night before surgery, they will clean the hair and all these things. They will betadine scrub and this. This movement of the fracture site will cause bleeding. So the next day you have to assess again. The previous hemoglobin will be around 9. The next day it may be 8.5. See the pulse rate, see the area, you see the tongue, see all these things to get the idea of there is no blood loss excess and our hemoglobin of previous recorded 9.5 is acceptable. Now this is our study assessment. This is about pregnant patients. If you can see here, our pregnant patients less than 10 is 50% around. And the guideline says 13 is around 2.9. So that is why I told so many guidelines, so many heroines, so many things are there. It's very difficult to take up all those guidelines. Personally, very difficult to adopt those guidelines in our setup. See, this is the preoperative screening. Blood is not an option. Multidisciplinary approach, optimized coagulation, adequate nutrition, B12, folate, etc. ESA use. This is what I told Darbafighting. Now we know the hemoglobin is less than 8, and if the patient is having urgent with hemodynamic compromise, you have to give blood. If the patient's hemoglobin is more than 10, yes, okay. If the patient hemoglobin is between 8 to 10 or something, 8.5 or something like that, then wait with iron if there is a non-urgent surgery. This is how we need to proceed because we know preoperative anemia is likely to cause more mortality, more likely to cause cardiac illness, more likely to cause renal illness. Get it up. This is what is the preoperative strategy. Now we go to the intraoperative strategy. Yes, decrease the blood loss by way of so much. This is now it's coming microprocessor control. Talk with the surgeon whether he is using tourniquet because sometimes there will be fracture in the lower humerus. Lower humerus fracture, some surgeon will do with tourniquet, some surgeon will not do with tourniquet because after tourniquet there may not be any place to put the knife. Talk with the surgeon about the blood loss, with the correct surgeon. Many times what we do in institutions, we talk with second year PG. We talk with second year PG, he'll say, no, blood loss will not be much. Then after that, the surgeon, original surgeon who is going to operate comes, no, the position is lateral and the blood loss is high. I cannot put tourniquet and all. So talk with the surgeon means talk with the surgeon who is going to operate. Hypotensive anesthesia, Viagra. Everyone knows Viagra, I think. But many of people don't know hypotensive anesthesia. Vasodilators, inhalational agents and IV anesthetics, adrenergic blockers, ganglion blockers. Geography means position change. Regional anesthesia is likely to cause less blood loss. airway pressure and PEEP. Once I will tell, one of the SRs was doing some surgery here, big surgery, major surgery here. And the SR has put the tube of 7 size tube for an adult male because it was a difficult airway. At all, we put a 7 size tube. And there was a lot of bleeding, lot of work. They took long time. And so what happened was we kept the tube because there was lot of tissue dissection and all these things in this area. So we kept the tube in the post-operative period. And Dr. Ravishankar came and simply he said, remove the tube. We took out the tube. Then he told that because of your small size tube, you have created a pressure inside high, and that is was causing oozing here. All was iatrogenic because of the anesthesia. So there was surgery was fine. Because the tube was removed immediately in the postoperative period, airway pressure became normal, bleeding stopped. So this has to be kept in mind. So I always give hypotensive anesthesia is a different topic. I always give beta blocker in any patients. I give 40 milligram of beta blocker for pranolol because what is necessary is hypotensive anesthesia to start. There will be sympathetic surge. This sympathetic surge will kill the aim of your hypotensive anesthesia. So start at the low dose beta blocker, 40 milligram, 1 hour before or 2 hours before surgery. Then you do this. Your hypotensive anesthesia will work well. Viagra will work well. That's what I told about geography. In thyroid patients, you just lift up the head like this. Your jugular is going to drain fast. Your pressure here is going to be less. Your bleeding is less. Similarly, like this, your intrathoracic pressure is likely to be less. There are a lot of things. Intraoperative cell salvage techniques. Here, wound circulation, again put it back. Long time ago, when I started practice in 1995, 96, what we do in ectopics, where we will just, the staff nurse will take out the blood and there will be 8 gauze pieces. And there will be a bottle, old glass dextrose bottle, which is again sterilized, again kept like this. They will make into the glass pieces, blood will, the filter is 8 sets of gauze pieces and we will give it back again. This was the first thing which I saw in 96, intraoperative cell salvage technique, and this is beautifully becoming more scientific and better suited for less side effects. This is what we have given hundreds of blood transfusion like this long back, but now it is not possible and we have to have an official approved guidance based cell salvage techniques. Very important. We always neglect this. We get the OT temperature to 26, 28 and patient temperature to 33, 34, 35 all. A normal prostate. Normal prostate operation. See the temperature, and because the water is flowing here and water is flowing from there also back. So bleeding will be more. So they are told 1 degree C, bleeding is 16% more. So get the temperature to 36. Don't keep it like this. Get the temperature to 36. It's a very simple technique of intraoperative anemia management. There are fluid warmers and there are body warmers. Now there are certain surgeries which we will not know. For example, a priming solution in cardiac cases. That I am not going into the detail of this. If your 1.5 liters of priming solution enters the circulation after you are starting your cardiac case, then see of this anemia. That is why in sick patients, in pediatric patients, they start with blood priming. Bone grafts. If you take a bone graft, they will suture it and put a big plaster. We don't know how much it oozes. Split skin graft, they'll pick up big things. So whenever your patient is posted for SSG, ask the surgeon what is the area, because many times it is completely rounded. We may not know which is the area to be grafted and which is the area from which they are going to take the graft. Then they will tell, I'm going to take from the right side also, left side also, because the wound is big. Then as soon as you, there will be oozing. After you are taking and fixing, continuously oozing, 100 ml every 5 minutes will correct sometimes. So keep in mind these things. Tonsil, nasal surgeries, because these things will be swallowed by the patient, and after he vomits only we will know he has already lost 400 ml of blood. After he vomits only we will know, otherwise he will not know. There are a lot of drugs Wanicock alpha, Sukotov alpha, I don't know whether they are English or not, Adnexan alpha, Argotravan, all these things. But what we know is this. We know tranexamic acid infusions. We know adrenal infiltration in acceptable cases. We know vasopressin in mammectomies. It is a short-acting vasopressin. But after between this, in this time, we should all suture it, get the arteries, get the feeder vessels tied. We are safe. So these are the three important drugs which are helpful in management of intraoperative anemia. Beware of ketorolac because this prostate and tonsil, they depend upon your natural coagulant mechanisms. We cannot go on prostate so many times tie it off. Yes, we do that. In tonsil also there may not be, so one or two things we will cauterize. But sometimes, and many times, we need a natural coagulation mechanism to work in PACA for any type of post-op bleeding to be decreased. So beware of NSAIDs in these patients. Use of diathermy has completely revolutionized your blood transfusions. Internal iliac artery ligation in placenta brevia. That is what now I give an idea to my physician. There is a placenta brevia. Start as soon as you deliver, just clamp the internal iliac and then do your hysterectomy or whatever it is, or placenta removal or whatever it is. Then yours. After everything is fine, you can remove these internal iliac arteries and see what is clamp. Remove the clamps and see. If there is any problem, you can clamp it again and tie it. In sick anemic cases, first tie the clamp at least the uterine arteries, then proceed with hysterectomies. There are a lot of vessel sealers and vaginal hysterectomies, so the bleeding is very minimal now. So these are certain small things which makes intraoperative anemia strategy very simple. This is a non-virgin clavicle. You see, I have done this case. Non-virgin means already clavicle is broken, plate is kept. Now the plate is broken. Now, if you touch it, there will be extreme blood loss. There is no tourniquet here. So that is a problem. So here, if there is a fracture, especially reopening humerus, there is no tourniquet. It is not virgin. We have already got some operation done. All these things, blood loss is maybe excessive. We should be careful. Especially when you have reaming, because it will not no, because if they will ream and where is the blood gone? It is not outside. Sometimes the BP falls, the blood loss is 300 ml in the reaming. Just again they will ream, another 200 ml will go off. Now, if you go and see now, that's what I told in the first. Start seeing so many journals will get confused. Acetabular fracture open repair, they say the acceptable or the estimated blood loss is from 100 ml to 2 liters, 50 ml to 1 liter. There is we cannot take this as a guideline anymore because the estimated blood loss is from 50 ml to 1000 ml, 25 ml to 100 ml, 25 ml to 500 ml. So we cannot take anything from here. We all know this MABL, EBV, HCT, initial minus target by initial. So what is the initial now? If we take 13 or 12 or whatever it is. Now what is the target? Some people say 8, some people say 9. Now this case is 8 or 9. Our institution puts only at 9. Sir. So this is the same it for chronic inflammation. Is it the same for CRF patients? All these things are so many differences in guidelines are there. And it also changes with BMI. Now your blood volume, estimated blood volume may be 45 ml per kg for this and 65 ml per kg for this. So that has to be also taken into account. Now I asked one of the transfusion experts, why are you giving blood? Why are you giving packed red blood cells? He simply said, whole blood is not available. As soon as we take the blood, we will make it into components and we keep RBCs. And each RBC is expected to rise the circulating by 1 gram. 8, if you give one packet RBC, it will become 9. That's all. And more than 20% of the estimated blood loss. Again, volume. If your volume is 4 liters, estimated blood volume. If you have more than 800 ml, beware. This is the intraoperative strategy. You can see so many things here. Laboratory testing, cell salvage, autologous, permissive hypotension, excessive phlebotomy, all these things. But what is important is diathermy, suture, antifibrinolytic, tourniquet, normothermia. You can see all these things. Now we have an idea of about intraoperative salvage. Now we will go to postoperative salvage. Worsening of preoperative anemia, perioperative blood loss, intraoperatively coagulopathy and phlebotomies, and continuing postoperative blood loss in the drainage tube. Postoperative reduced erythropoiesis due to surgery. And sometimes, we will not know the amount of blood loss, especially in prosthetic surgeries. Prostate, there will be saline going on and the blood will be collected. We don't know how much is the blood loss. Because 5 liters of saline has gone in, the next day we have taken out this thing that is reddish and maybe 500 ml blood loss or 1 liter. So these has to be taken care of. What is the chemistry behind this? Inflammatory cytokines after surgery can lead to a cascade of effects. Epsilon increase. There is a problem. So iron is not available. Active inflammation, decreased iron intake from the exons. Erythropoietin becomes a waste because of this inflammation. So all these things this chemistry makes a postoperative anemia feasible very easily in a patient. So ginkgo, ginseng, garlic you may be taking. You may not know. That may be a problem. Inappropriate bridging heparin. We are absolutely not worried. We go into the preoperative hemoglobin, blood count, platelets, all these things. Who bothers about postoperative hemoglobin, platelets? Nobody. I have seen how many consultants go and see what is the postoperative hemoglobin? Very less. So we are not putting a blind eye towards postoperative iron, postoperative heparin when they are starting, postoperative propylate when they are starting. All these things we get opinions and we don't know what is actually happening and then land up in problems with bleeding and then retake all these things. So we have to go and to the postoperative ward, see the blood loss. Said yes, we can also give erythropoietin and start iron infusions in the postoperative period day too. Nothing wrong. Yes, I have seen already gastric bypass surgeries. We have to go for parenteral. We cannot put something with the right tube aspiration on. So these are all the things which we may need to have an open eye, not a blind eye like this in patients in the postoperative period. We are more concerned with preoperatives. Avoid unnecessary phlebotomies. I can see their books say 40% of postoperative anemia are due to phlebotomy. What is the phlebotomy? Take blood, 15 ml, 20 ml, take culture, take all these things, blood culture, the culture, take LFT, RFT, CBC, coagulation profile daily. So beware. Is it needed? Think about it. And many times the CBC and RFT are not seen by the surgeons. Somebody else sees those hemoglobin is. So phlebotomies, LFT, RFT, LBC, not like this. Do an investigation, hemoglobin, preferably on day 2 or 3, where it will reflect the hemoglobin levels clearly. What is permissive anemia? The concept of permissive anemia is based on the principle that low post-op hemoglobin levels are well tolerated. Don't give. Little less hemoglobin is well tolerated in the post-operative period. So these are all the guidelines. Again, I see optimize hemoglobin recovery. Nobody uses post-operative erythropoietins at all. Folate, B12. So there are two things: liberal transfusion and restrictive transfusion. This liberal is around 9-10 you give transfusion. Restricted is around 7.5 to 8.5 only you give transfusions. These are all the complete guidelines. So what I want to tell is what is pre-op anemia. That itself is a confusion, either 13 or 10. What are the causes? Treat the cause. And you cannot wait for treating the cause if the cause is going to be a bleeding piles or a DUB or anything like that. I have seen a case of an ovarian cyst coming to the preoperative clinic and rejected for anemia, and in the afternoon it came as ectopic, the same patient. So also this is possible. Look at the patient's pulse. Then you can give blood in cases of urgency, in cases of hemodynamic compromise, if the hemoglobin is very low, like less than 7. Intraoperatively, tourniquet or not. The drugs are not. Stop all drugs, clopidogrel, heparin, whatever the patient is getting, aspirin, whatever the drug according to the guidelines. Keep the position. Thyroid means simple. Keep the position. Talk to the surgeon. And what is the surgery? And what is the surgeon? Who is the surgeon? That also has to be found out. Postoperatively, see the drainage, lab test. Postoperatively, also we can use iron, darbepoetin, erythropoietins, and all. There may be some pressure to make patients fit. Yes, what it is, give blood and take it. You tell the surgeon, convince the surgeon. Yes, we can do the case after 3 weeks. It is only vaginal hysterectomy. Don't bother about it. Initially, the management, if you say, it is a cost-based strategy. Secondly, it becomes a case-based strategy. If you remove you, it becomes a case-based strategy. And it is preferable to have institutional guidelines of how to give blood and when to give blood perioperatively, or when to give iron, because many surgeons may not like your erythropoietin injection and come back again. So you have to have institutional guidelines for this. Make up a team of surgery, orthopedics, gynec, anesthesia, transfusion medicine, and a hematologist. Make up a team and give the guidelines like this. The guidelines are not for all cases. Yes, it's a case-based strategy. Just because it's telling something like that, a septic peritonitis is unlikely. A peritonitis can come with CRF. A sepsis of the wound can come with diabetes and CRF. That I cannot expect a hemoglobin of around more than 7. That should be made a case-based strategy. Thank you all. Thank you for patient listening. Visit my YouTube Pain Free Partha and visit my website www.painfreepartha.com. Once again, I thank the organizing team for this wonderful opportunity. Thank you.